Hello, everyone. I hope you're all doing well. I'd like to welcome you to the Journey to Healthcare series. And today's episode is going to be all about diagnostic radiology. And we have Dr. Mohamed here with us. Would you like to introduce yourself, please?
So hi everyone, my name is Mohamed Al-Sharji. I am a PGY2 in diagnostic radiology here at the University of Toronto. And it's a great pleasure to be part of this interview in exploring different medical specialties.
Yeah.
Thank you very much, Yamama.
Thank you. And I'm really looking forward to learn more about it. So let's go to the basics. What is diagnostic radiology?
So diagnostic radiology is a medical subspecialty where we basically focus on diagnosing different wide range of medical pathologies using different medical modalities or medical imaging modalities, whether it's an X-ray, it's a CT scan or an MRI or fluoroscopy. Many other departments or many other specialties depend on us in order to give them an accurate diagnosis that would help them in planning their management plan for the patient. We are also involved in performing several procedures that could help the treating physician. For example, in interventional radiology, we could do some PICC lines or portacath insertion. In patients with, for example, limb ischemia, we could go in with a percutaneous, like through percutaneous angioplasty and like balloon up those occluded vessels. And maybe insert a stent. Other procedures, for example, in patients with stroke, we could do a mechanical thrombectomy. If it's within the window period, we go inside through the wires and catheters, and we try to identify the area of occlusion, and we try to mechanically either thrombolize it, either remove it, or like thrombolize it through intraarterial treatment. So it's a very interesting specialty. It's not only purely diagnostic, but there's also some other procedures, including biopsies. I forgot to mention that. So we do like liver biopsies, prostate biopsies, breast lesion biopsies, so on and so forth.
Oh, interesting. I didn't really know about the biopsy part. So why did you choose this field?
So it's an interesting story. So I wanted to become an internal medicine or internist. At the beginning, during med school, I even worked hard to become an internist. I was highly specific. I wanted to become a gastroenterologist.
Oh, wow.
But then, as I went through my internship year, I realized what were the things that are really important to me. And to me, the top priority was I wanted to have a very good, I wouldn't say like an excellent, but at least I wanted to have a decent, good social life. Or at least I wanted to have a good balance between work and my personal social life. I found internal medicine to be a really great specialty. Until today, I really love internal medicine, to be honest. But then I realized that it was a bit more hectic, I would say. Like you would get a lot of on-calls and you would be called in the middle of the night, for example, for patients like with active GI bleed, or like patients with stroke or whatsoever. Although you get less of these calls as you become more senior and you become like more of like a staff physician, but still you're still under that level of stress and adrenaline rush where you always have some urgent cases coming in and you have a big volume of patients to take care of. So I thought maybe, okay, I could do this for the next maybe 10 to 15 years, but is it going to be something that I want to do for the rest of my life? Then I started thinking and exploring some other choices. I thought about histopathology because they have a very good balance between life and work. I also thought about dermatology, ENT. From the very beginning, I wasn't a surgical person. So I knew that all surgical specialties are out of choice. But then I met one of my mentors who was one of the greatest gastroenterologists, and he told me, hey, listen, why don't you go to radiology? It's advancing really fast. And if you go through interventional radiology, you would be able to do a lot of life-saving procedures and a lot of interesting stuff. And it's a specialty that many people probably are not really aware of until like they find themselves in a particular discipline that they depend on, like the interventional radiologist. So I thought, okay, maybe I should give it a shot. And at that time during my internship, I had this habit of like looking into images, like for example, CT scans of the head, chest CTs, X-rays, and I would try to interpret those without seeing the report. And then I would come up with a conclusion. Okay, I could see that there is a hemorrhage here, or there's a consolidation. And then I go and read the report. And it feels really good when you detect a finding and you find that it's compatible with the final report. So I felt that, okay, maybe I'm fit into this specialty. Just answering your question, I also had the same question in my interviews for residency, like why do you choose, or why did you want to come into radiology? And my answers were like, I had 3 to 4 answers. The first one was, we cover a wide range of pathologies from head to toe. So basically, you know almost everything. It's very rare to find a specialized physician who knows almost everything. And probably we are one of the very few physicians who could speak with other physicians and like be at the same line without any particular difficulties. For example, I could speak with a general surgeon and we could both understand the same language. I could speak with the orthopedic or to the orthopedic surgeon. I could speak to the ophthalmologist, to the ENT surgeon, to the gynecologist, internist, just name it. So unlike when you're like highly specialized in like something like ophthalmology, you only specialize in ophthalmology. So you have nothing to do with general surgery or cases or orthopedic cases. That's number one. Number two is that it's highly advancing. We started with basic stuff like X-rays, and now we're talking about things like functional MRIs. We're talking about interventional procedures that are life-saving, like in stroke embolectomies. And the third thing is that there's a lot of flexibility in radiology, is that, and in terms of, like, for example, if you're a person who just want to read images, you could spend your whole life just reading images and that's it. If you want to do procedures, you could like take something like women's imaging, where you would be doing mammograms and then doing biopsies. If you want to do more, if you want to have more patient interaction, you could do interventional radiology, where you would be basically just doing procedures. And a lot of these are really interesting, really amazing stuff to do. And in addition to that, now we've reached a particular stage in radiology that you could even work from home. You don't need to be in the hospital. You don't need to be attending hospital. A lot of our staff radiologists actually report from home. They could just see their report, see their images through the PACS system and put their report, and that's it. Like you're sitting on your couch, sipping your favorite cup of coffee or tea and listening to your favorite music and just reporting images. And that's it. Like, I find that to be really fascinating when you have a lot of flexibility in your work.
Yeah, that's interesting. Actually, when you were talking, I was just about to talk about, I think it applies to telehealth, but you already answered the question. So yeah, and I think it's interesting because you get to see a large number of patients, and do like the number of patients that you actually see is quite a lot compared to other doctors. Yeah, but I think that proved that they always say you enter med school wanting one thing, you go through like so many changes, and then you end up with something totally different.
Absolutely, that's totally right. Because you know, during med school, this is what I was so fixated about internal medicine that I was not into any, like, there was no way that if you would discuss with me about any other specialty, I would be convinced. But you know, sometimes you just gotta open up your mind and explore other specialties and see what are the benefits and the downsides of that particular specialty. And unfortunately, radiology is probably not one of those highly focused specialties in med school, which makes sense because, you know, you require a lot of basic knowledge in order to be capable of interpreting these images. So you need to have very good cross-sectional anatomy. You need to understand the basics of imaging in order to be capable. And basically, you don't need that as a general practitioner or as a general physician. You could just develop that practice of looking into images with time. But I find radiology to be more enjoyable. The more you know, the more enjoyable it becomes. And that's the reason why we find a lot of medical students become hesitant in getting into radiology, because they find themselves, they know more in general surgery, they know more in orthopedics and internal medicine and pediatrics, but they know nothing in radiology. So they're like, why would I choose that specialty? It's vague. It's like throwing myself into the dark.
Yeah. So if someone wants to become a radiologist, what is the path?
So the first radiology program is composed of 5 years in Oman and also here in Canada. I think in some other countries like Saudi Arabia, they would do a total of 4 years. The first year is usually like, so back in Oman, the first year was like, you go directly into radiology. Like you do radiological rotations, like plain radiograph, CT, MRI. Like for a whole month, you'll be interpreting MRIs or like just CTs or fluoroscopy images. Or it's based on disciplines. So for example, you do 1 month of chest radiology, 1 month of body imaging radiology, where you cover abdomen and pelvis, 1 month of musculoskeletal radiology, another month of neuroradiology, and so on and so forth, until you finish your residency. Here in Canada, for example, we have a different system where the first year you rotate on different clinical rotations. Like for example, you do 1 month of OBGYN, 1 month of internal medicine, you do 2 blocks of emergency medicine, and other clinical related or clinical specialties. And then once you're done with your first year, you directly get into the pure radiological rotation starting from your second year. So by the end of your 5th year, you do your final exam. And once you're certified, then once you get your certificate, you're able to practice as an independent radiologist, general radiologist. And then if you want to highly super specialize, you could do another 1 to 2 years in something like, for example, neuroradiology, musculoskeletal radiology, or like, for example, head and neck radiology whatsoever. And it's actually, you'd be surprised that it's a very, very huge specialty in such a way that sometimes you would find someone who has been practicing as a thoracic radiologist for so long. With time, they tend to tell you that I'm not really good with MSK radiology. I'm not the right person. So go to someone else. Go to someone who is highly specialized in MSK radiology. Yeah.
Interesting. So what's a typical day like for you?
So a typical day as a resident would be like, I would start my day at 8 a.m. in the morning. We would start with rounds for like an hour. Generally speaking, our rounds are not like the clinical rounds where you rotate on patients. Our rounds are basically teaching rounds. So you attend the seminar. Previously it was like in person, but now it's like through Zoom or like Microsoft Teams. And there would be like a mentor who would be showing a bunch of cases, and each person would like volunteer to pick up a case. And like you would start with, what do you see and what are the findings that are like that you're able to detect. And then you could come up with a list of differential and give give like a particular diagnosis and give a particular management plan. And the mentor is going to tell you what are the stuff that you've missed and what are the stuff that you could improve, and would give like a brief overview of that particular disease or that particular pathology. Sometimes it's more of like a lecture, like the mentor would prepare something, let's say approach to stroke imaging or approach to lung nodules, and would spend the whole hour with like going through these slides with some discussion. And then once we're done with the morning rounds, we go into our respected workstations where you have your own monitor and your own place to work, and you start reporting images. So depending where you are situated, if like you're doing thoracic radiology, then you would be most likely reporting chest x-rays and CT of the chest. If you're doing, for example, body imaging, you would be reporting CTs of the abdomen and pelvis. If you're doing pediatric radiology, you would be somehow spending your time between reporting x-rays, doing ultrasounds on different patients. If you're on ultrasound rotation, you would be spending the whole day just performing ultrasounds and reporting it. And by that, usually, so after each particular time interval, like let's say 2 to 3 hours, the staff radiologist or the consultant would tell you that once you're done with a bunch of images, let's review them together. So you would go, like, you would tell them that I reported, let's say, 7 CT scans, and I would like to review them with you. So he would go one by one and tell you, oh, okay, you missed, there's a lung nodule that you've missed here, or there was a finding that you didn't mention that you should have mentioned. And they would also go through your report and maybe make you tell you about how you could somehow improve the wording and the way how you format your reporting. So, and we go on until 12 noon, where we basically grab a lunch. And that's probably one of the best things about radiology, is that you have a lot of flexibility. So in some other specialties, sometimes you might not have time for lunch. You're so busy dealing with patients, trying to answer pages, trying to finish all the tasks before the end of the work day. Otherwise, things will keep on pending. So in radiology, we don't have that. We just go grab lunch, and then at 12 we have another round, teaching round, where we sit, eat lunch, and at the same time listen to the presentation or the lecture, or maybe take different cases. And once we're done with that 1 hour, we go back to our respected workstations and do the same thing till somewhere around 4. We review all the images with the staff radiologists, and by 5 you're done. There is no reason for you to stay in the hospital.
Oh, interesting. So you don't have calls, or do you have?
We do have calls, and that's probably the worst thing about radiology. That the calls are very, very busy. It's very hectic, and it makes a lot of sense because you're covering the whole hospital, and every single department is like trying to reach you in order to request, for example, an ultrasound, or like in gynecology, they would sometimes request for an ultrasound to rule out ovarian torsion, or like ectopic pregnancy, or even the emergency physicians would do that. CT scans to rule out appendicitis, or like aortic dissection, head CTs for a patient with altered mental status to rule out any stroke or like any intracranial hemorrhage. So it becomes really busy during the call, and I wouldn't joke if I told you that the pager doesn't, like, literally, like, it keeps on it keeps on bleeping every now and again, and it sometimes becomes really annoying. Like, you lose your nerves, and and you become really aggressive with some of the other physicians. Why are you requesting this? Why are you doing this? But, you know, I think for me, like, this was at the beginning when I was starting my own calls, but by now I'm like totally fine with it. And it's part of your job. Like, we're helping patients. We're trying to do something really beneficial for the patients and also for the physician. But yeah, if there's anything that's really bad about radiology, is that the calls are very busy. And here in Toronto, I cover 2 hospitals, actually. It's back in Oman, we used to cover a single hospital, but here, because we have the teleradiology and other hospitals can send their images through the PACS system to the domain or the main hospital. So we receive images from both hospitals, and we cover both sides. Yeah.
That's interesting. So how many patients do you see on an average day? Around how many patients do you?
So it's very variable. During the daytime, you could see, like, usually I would always say that my highest number of patients would be during the on-call, because I'm alone. Yeah. I'm covering the shift all by my own, and that's where, like, I could count my volumes, and usually on an average during a single 12-hour shift, we don't do any more 24-hour shifts, because basically it's very busy, and it's a service that is very highly needed and highly demanding. So in 12-hour shifts, I would cover maybe around, I would see probably 40 patients, different modalities, CTs and ultrasounds, and sometimes we get some MRIs. On a regular day, because, you know, in a regular day, it's more of like reporting full reports, making sure that you get the full learning experience, making, like, you're trying to make your reports as fancy as possible. So I would say it would be variable. If, like, on my last musculoskeletal rotation, I would pick up around maybe 15 to 20 X-rays. And then I would do maybe, let's say, around 7 to 8 MRIs, and maybe sometimes I would do around 2 to 3 CTs. We get ultrasounds in between. Probably I would do around maybe 2 to 3 ultrasounds, and maybe I would attend 2 to 3 procedures like intra-articular, hip joint injections, or like shoulder arthrograms, or like facet joint steroid injections, or for example, nerve blocks. So yeah, it's very variable depending on which rotation. But usually during the on-call, I would say we do around 35 to 40. Sometimes it could go up to 50 if it's crazy busy. It's very variable.
All right, so we talked all about the positives. What is like your least favorite part of field?
So my least favorite, number one is probably if you're a person who really likes dealing with patients. I wouldn't say radiology is not the right thing, because I personally love dealing with patients, and I felt it at the beginning of my residency that I really missed that patient interaction. But you know, it doesn't mean that you're not dealing with patients. It's all in radiology. We do a lot of procedures, and we do consent the patients. We do explain to them the purpose of the procedure, the risks, and also the benefits, and what sort of complications to expect. So we do see patients when we do fluoroscopic studies, ultrasounds, whenever we do any interventional procedures, like for example, biopsy or angioplasties. So that's still there, but it's not as heavy as in other specialties, where you basically, the patient is the center of your work, especially in pediatrics and internal medicine, gen surg. So sometimes I do miss those days. But you know, it's a matter of balancing what are the stuff that you're looking for in a specialty. For me, I was really enjoying radiology, and I still do enjoy radiology. And the more you progress, the more you actually enjoy the specialty, because you know more. And the other thing that I really consider as a downside in radiology is that you would do a lot of stuff, but sometimes you might not get like the appreciation from the patient directly. So a lot of the CT scans of patients with cancers, like early stage cancers, will be detected by us. And then like the patient wouldn't know that it was actually detected by us. He would think that it's actually the primary physician who detected it. But actually it's a mixture of both of us. So the primary physician suspected it, and he requested for that particular modality of imaging, like a CT scan, and we detected it, we reported it. So you don't get that thing, but honestly, I don't find that to be a really major issue. The on-calls are really stressful, and if you're a person who is not capable of working under stress, but like let's be honest, there's no medical specialty that's like, in on-calls in general, you would always be dealing with stressful situations and like higher number of volume, like higher number of patients. So I don't think that's something unique to radiology. I think it's almost in every other specialty, but in radiology, it's just because the fact you're covering the whole hospital, it becomes a bit more intensified. The good thing about it is that you don't need to, like if the patient deteriorates, it's not your responsibility, it's the physician's responsibility. You only report images and send the reports and convey them to the physician as soon as possible.
Now it's a bit of a more fun part, like the stereotypes of radiology are like, is it true like you always sit in a dark room, or what are some myths that you think are common but you would like to debunk about the field?
So yeah, so the stereotype about radiologists liking to sit in dark room, it's not that we enjoy that. In fact, I'm a person who hates sitting in the dark. I love going outside, enjoying the sunny weather, but it's just a matter of, it has to do with our work setting. Like for example, you don't want to be distracted with any ambient light that is surrounding your monitor. So you would rather keep everything, all the lights dimmed. So you would focus on the monitor, and you would be able to pick up some subtle changes or subtle findings. A lot of people would tell you that radiologists hate patients and they're very introvert. Part of that could be true, and I'm saying part of it because a lot of those who probably felt that they don't want to deal with patients anymore would go to specialties like radiology, maybe histopathology, because there is very limited patient interaction, but it's not necessarily true. A lot of the radiologists actually do enjoy dealing with patients. I've seen radiologists who would go and actually visit the patients in their ward after the procedure just to make sure that everything's okay, that there is no any particular complication. They would also see the patient in the clinic. And nowadays, that's another good thing about radiology is that, or interventional radiology, is that we could also see patients in our clinic and consult them, or counsel them and talk to them about the procedure, assess them, whether they really need the procedure or if they could wait. And then after the procedure, we go and follow them up and see if any complications arise, if they're doing well. So it's like there are these stereotypes, but not all of these are like 100% true. I personally enjoy seeing patients, and like there is if I had to choose between seeing examining and seeing patient at the same time doing radiology, probably I would have done that. But in radiology, you're very limited to a particular number of tasks.
Yeah, and I think you also do a lot of communication with other doctors, so there is still like a huge communication aspect involved. It's not even, I think, in pathology, but you also communicate the results, and that's also it's not like you're completely isolated.
Yeah, so whenever there's any particular result that requires to be conveyed as soon as possible, we try our best to reach to the responsible physician in order to make them aware, because sometimes we could release the report, but until they open up the report, a lot of time might have passed. So and it happens with a lot of incidental cases. So sometimes a patient might come in for for example, a completely different reason, just imaging their stomach, their abdomen, looking for any particular finding. That particular finding of suspicion is negative, but then we realize that, oh, there's a tumor there, and no one knows about that tumor. So we need to inform the physician so they could at least expedite any particular workup.
Interesting. So to sum it up, what advice do you have for all aspiring radiologists watching this?
I'm trying to remember, if I were as a junior physician or as a medical student who's aspiring to radiology, I would say take your time in exploring your career choices. Don't rush. Don't be fixated on any particular specialty, whether it's radiology or outside radiology. All specialties are amazing, and I always say that there is nothing that's better than something else. It all depends on what's your passion and what sort of lifestyle you want to have. Obviously, if you want to have more social life, you shouldn't be going into neurosurgery. Okay, and I'm not saying that because I really love neurosurgeons and I work along neurosurgeons all the time, but let's be honest, it's a very busy service. So take your time, explore your choices. If you're really interested in radiology, try to apply for some electives or selectives. Try to work on some research or case reports. Sometimes it's difficult to find someone who could hold your hand and take you to the right path. This also happened to me until I met with one of my mentors and he guided me. But always feel free to reach out, any of your senior colleagues or any of the staff radiologists. Tell them that I'm interested in this specialty. What do you think? What do I need? What should I do in order to get accepted? Because radiology is somehow highly competitive, especially in the Western countries, in Canada and in USA. It's one of the top competitive specialties. And if you would, in USA now, they have a special residency program in interventional radiology, and it's being considered to be the highest, most competitive specialty so far. Before it was dermatology, but now it's interventional radiology. The other thing is that I always say, whenever you're making a plan for your career choice, always study the market. You shouldn't be just choosing a specialty that is so congested in your particular area. So if everyone's pediatrician, you shouldn't be choosing pediatrics, because basically it's going to be a hustle finding a particular job. You could always go outside, but you should always make a balance between what the market needs and what are your passions and what are like your priorities in life. So it's a mixture of different factors. Whoever tells you that you should only focus on your passion is not 100% accurate. I don't think that's really accurate, because we've seen a lot of physicians who have been following their passion in a particular specialty, but then with time, they realize that, hey, maybe I should have taken something else. Maybe I should have taken something less busier, or maybe something more involving, or so.
Yeah.
So don't be fixated. Just open up your mind. Try to explore as much specialties as possible, even specialties that you might not have rotations at, like for example, forensic medicine. If you think that there's a potential, you could do that and try to explore it. You might like it. So yeah.
I totally agree, especially with idea of being more realistic, because sometimes also thinking okay, now this is my mindset right now, but would it change after 10 years? I think that's also important to keep in mind and ask these questions. So yeah, thank you so much for this. I really enjoyed it a lot and learned a lot from you. And I'm sure that everyone found this really helpful. So thank you, and I hope you have a good day.
Thank you very much, Yamama. It's been a great pleasure and an honor. I wish you all the best. And if anyone has any particular questions, they could always reach out. I could send you my email, and maybe if anyone has any questions, I'm more than happy to receive any particular queries in regarding to residency or radiology in general for medical students or even interns. Thank you very much.
Thank you so much.